There, can you see that?
Yeah, we can.
Okay, so let's go for it then. So I see this cartoon a lot on Facebook, and it's true. We do only live once, but not. We die once. We live every day, and that's true. I think more and more we're thinking about how do we help people live with terminal illnesses and life-limiting conditions. And Snoopy, a lot can be learnt from Snoopy, I think. So the topics, I'm aiming this at health professionals, and it is caring at home, obviously for people with life-limiting conditions. Um, I've kind of based this on, I guess, things I've come across and also complaints that we've dealt with and sort of recent issues that have come up. So it's kind of, yeah, it's just going through a few general things, but I tried not to overlap with some of the other sessions we've covered. So it's supposed to be quite quick, and I'm going to try and be quick, but we definitely are looking at preparation, coordination, compassionate and effective care, available support, and spiritual considerations. This is aimed at Hillingdon, so I'm hoping that some of the detail about the available support will help everyone because it's about local support. So what do we all know? We all know that the world is getting bigger. People are living for longer with more complicated illnesses. It isn't a subject that's going to go away. And as Ros said, this is going to become much more a pertinent thing to think about. How do we look after people? And how many people have you met, I guess, who were carer for their loved one, then they themselves get a terminal diagnosis, and then both of them need care, and not many people want to be placed in a placement. And will we have enough placements? No. So it is going to be about how do we make homework. Preparation. I just looked for stupid pictures. Preparation is most certainly key. And I guess what I'm guilty of this as much as anyone is talking to people about end of life care, and particularly families, and not necessarily thinking of what they don't know. And people don't know what they don't know. You know, a lot of people get to quite an older age, luckily, without caring for a loved one at end of life. You know, they may not have lost someone. You know, people are living for longer. So it isn't something that everyone automatically knows. Now, the link on here, I think you guys can send out the PowerPoint slides to people who come. Is that right? I'm hoping it is. Because I've attached some links here. And this is actually nicked from the HPAL website. So this is the Hillingdon Health Partners who came together to create a Hillingdon Palliative web resource. The link there takes you to some really pertinent, really good videos that the Marie Curie service kind of put together, aimed at informal caregivers or family caregivers, on how to do really simple tasks like bed bath someone and different things, but it's broken down in really helpful chunks. It's really nice to access it through this website. So that's why I've linked it that way, because honestly, the amount of carers I do meet who are like really thrown by the idea of being responsible for someone they love at end of life. And we all know that even with the biggest care package in the world, they will be on their own with their loved one. That's going to be a definite thing for periods of time. The other thing that I've made a spelling mistake. The other thing I wanted to push is the carers training. So again, this is kind of another, along with the HPAL website, when looking at kind of how we can improve end of life care at home, we thought about how can we improve information for family and family caregivers. And it was recognized that it would be really helpful to do some actual face-to-face, although this is Zoom to Zoom teaching at the moment, directly with carers about how to look after someone at end of life. So I've put here Lynn's email address because she's very happy to have information emailed about carers who might be appropriate. This is aimed at people who are caring at home for people that they love who've got a life-limiting condition. It's a rolling program, and we've got dates for the rest of the year. Each session, there's kind of like 3 sessions in a group, and they cover kind of what is palliative care, what would care at home look like, and then how to deal with death and dying and kind of at home and what that would look like. So I really would advocate it because obviously we need the carers to keep it going. And you guys are the gatekeepers to getting to the carers. So I really appreciate if you do think about who you come across. And the other great benefit is Lynn is linked with the Carers Trust. So by getting them in touch with Lynn, they are kind of automatically then accessing the benefits of Carers Trust, who do great stuff like gardening on Zoom, getting your garden ready for spring, and therapeutic gardening and art classes and different things. And at the moment, in a COVID world, it is aimed at remote sessions, but actually if people have got caring commitments, that kind of works quite well right now. So I'm plugging that. So family caregivers, this came from the Voices National Bereaved Survey, Voices, which some of you probably have heard of before. And it's kind of looking out at kind of what family report back, and a lot of it is not surprising, not feeling that people have got enough time to ask questions. And I think, I think about the fact that district nursing may be seeing 20 people a day, and actually, it's very quick, 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 quick. Are you able to give people enough time to ask all the questions? No. And sometimes the way we come across, and I know I'm guilty of this, I look like a manic headless chicken, and people don't feel able to ask the questions they might have. So it is, it's something we should, I guess, all be mindful of. But at the same time, I'm very aware of how busy everyone is. The quote there about the local health watch survey, that was talking about a lack of coordination between services and slow response, also repetitive answering of questions. This wasn't specific to end of life. This was about general healthcare in Hillingdon. But again, I'm guessing that there's no surprises with that kind of comment being made. But I guess there are definitely things that we as individuals and teams can do to try and particularly improve coordination. So preparation, your role. I mean, this is, I think, everyone's role who's involved in end of life care, but obviously everyone has different levels of knowledge about certain things, and often it's about where do you go to get more information if you know that that's needed. But what we definitely know is prognosis is really important, although very difficult, and sometimes it is purely about explaining how to live well, how people might need to live with uncertainty, and that's okay. It's really difficult. We all know that false optimism and geeing people up is definitely not the right way to go. And it's just about kind of how you reassure family caregivers what might happen, but also the patient themselves. Have they had an opportunity to ask things? And I know from my student nurse days, it was always when you were giving someone a bed bath as a student nurse that they would ask you really difficult questions. And I remember being in that situation thinking, oh my God, what do I say? Yes, I think you're dying, but am I allowed to say that? And and you really worry. But I think, people do choose, their own time of when they want to know things. And it's really important not to shut people down. Obviously, you don't have a crystal ball, but it's just important to reflect back. And one of the best things I've been taught about prognosis is kind of how quickly are things changing. Is that person noticing changes on a month by month basis or week by week? And when I mean changes, I mean in terms of worsening in their condition, and that can be quite helpful. But we all know people who go well beyond their expectations, and I would say with chronic conditions, it is often harder to predict. I think, really allowing people time and space to express their fears and anxieties. Often their fears and anxieties are things that will never happen. And actually, you can really reassure that. Or alternatively, they might be things that could well happen, but then I guess it's about telling people what safeguards you're going to be putting in place to try and make it as manageable as possible. It isn't about false hope. It's about kind of, it's about planning and involving the patient and making sure that you really do understand what they're worried about. Those people who are worried about being buried alive, they are many, more than I realized. And that's, a fear that people might have. Unless you ask or give them a chance to ask it, you don't know that. Contact numbers. I think, our patients, how many professionals do they meet in one day, even let alone 1 week? I think it's really important sometimes to summarize. And I think I've always liked that about the district nurse folder, having that one front page with the different contact numbers and what the teams do helps, because they lose track, and we're meeting people at one of the hardest times of their life in a very intense time often. So I think it is just really important to check back that they remember. What your Lifeline have started to do, because they're a responsive service only, is after 6 weeks they send out a sticker with the number of the service and a reminder that you've got use of the service, with the idea of sticking it on the fridge so that number's there for them ready to use. And it's just trying to think of creative ways of making sure that people understand who's involved and what their role is. Funeral directors. Now I put that in because I kick myself about this, particularly doing your Lifeline overnights at Christmas. the amount of people I met who hadn't even remotely considered what they would do if their loved one dies at home in terms of funeral directors and what their responsibilities was. And I am serious when I say that someone did actually think we were going to take their dead relative away with us in my car. That's not happening. We just have to kind of really think people haven't been in this situation before. And I think sometimes they really do think we're going to do it all for them. And it's just about being really clear what they're going to be responsible for, but what you can help them with versus what you're really going to be kind of managing. And I think it's in everyone's interest, because it's quite hard at 3 o'clock in the morning for them to suddenly be thinking about who to phone and how it all works. But again, I think it comes down to who feels responsible for it. And it often might just be putting it as a have you thought about funeral directors yet versus any other more direct guidance than that. It's always useful to know funeral directors do operate 7 days a week, 24/7, but there is often a extra fee to get them to come out of hours. So I often say that to families and say, you may just want to wait until daytime hours, because they don't have to have someone taken straight away. And it's just silly things like that. Coordination, our favorite topic in the health services. So the right time, the right help at the right time from the right people, that is key to all of this, isn't it? And it sounds so simple, and it's so not simple. I think communication between all our services is most definitely key, and obviously GP meetings and handovers between teams can be really helpful. I mean, coordinate my care. I love it. I think it is invaluable. But we all know that there are bits which make it tricky for everyone to access and use. But at the moment, unfortunately, it is the one shared record that we potentially all have access to that will say the pertinent information about that patient, including plans for if things get complicated. Documentation. So we're lucky in the CNWL services to have access to System 1, and we can access the EMIS System 1 interface, but that's not total. And in the hospice, they have CMC, but they don't have access to System 1. It's everywhere is limited. So it's about thinking how to be creative and make sure that the right information is handed over and with the right people. We are more and more trying to really highlight the importance of a GP face-to-face or video review within 28 days. And I mean, and that's kind of manyfold, in as much as for us as nurses to verify a death, we need that to have happened. For the GP to just be able to do a death certificate without needing to speak to the coroner, we need that to have happened. And I would say also for the family and the patient, it's that feeling of being cared for. And I know that maybe sounds silly and I don't know, a bit trite, but I think it is, this person has been recognized as having a significant change in condition. It's been recognized that they look like they're approaching end of life. And for families and patients, it's really meaningful when the GP makes that contact. And I would say it's probably quicker than picking up the phone to the coroner, but I may be wrong. Anticipatory prescribing and MAR charts. I'm not talking about MAR charts in detail here, but again, it's just making sure that we've got the right things in place, including the chart that is usable, that the drugs are there, that we know where they are. The last thing we want is to be in a crisis and not know where any of these things are. And again, it's silly things like families sometimes giving these drugs back because they're not using them right now. And we're not always great at explaining what these drugs are for, or the families might change over and different family come. And we have definitely had incidences where anticipated drugs have been given back to pharmacy because they weren't being used right now, or they've been put in a puff that's been moved upstairs and no one remembers where it is. So it's kind of important just to really clarify to families the language that we might use, like where are the just in case drugs, where are the anticipatory drugs, and then where are they all going to be living that we're all agreed on. On our old pink charts, which I know everyone mourns the loss of, we actually used to document where the drugs would be kept to try and avoid this problem. I said funeral director again because that's how important I think it is. Compassionate care. I think we'd all agree that most of us come into the health services with the idea that we would want to be involved in compassionate care and that it's important to us. I think I was struck recently that maybe we've stopped allowing ourselves to think that's important, or we've not prioritized it, or we think it's weak, or we worry we'll get burnt out. I don't know. I think there's various reasons where it's become less recognized as being important, and actually it's one of the most important things, I would say, at end of life particularly. You are meeting people at the hardest time, and you can make a huge difference with really simple small things. And I was listening to a TED talk that was done by Rachel Clark a few weeks ago, and she very much was saying the take-home message that she'd had from a patient one day when it was the middle of the pandemic. It was a complete mess. He just had a massive hemorrhage. He just said to her, the most important thing is to transmit love. And that's for us to transmit love to patients. That they do count, that they do matter. They're not just another number. And I think that is hard. That's hard. It's asking a lot. And I am not saying you need to sob at the bedside with them, because equally it's about transmitting love without feeling like you need looking after. That's a balance sometimes, but it's about showing that you care. This week I heard a lovely after death care story. One of our young patients, who some of you will know, died last week. He was 21. He'd had a neurological condition for a long time, and he died in hospital, which we're not surprised about. We kind of thought that would be how it would be. We're not taking that as a failure, because he knew that team very well. And do you know what they did? When after he died, they wrapped him up in his Spider-Man duvet, did not put a horrible shroud or the horrible kind of boxy bit over the bed to take him away, because that's what his mum really wanted and said was important, that it looked like he was just sleeping when he was taken down to the mortuary. And it's things like that. So sometimes it's about bending rules and maybe breaking rules, which the hospice are much better at than us. And doing it for the right reasons. It is about making people feel like they matter. And we have only got one chance to get it right. So challenges, my goodness, there are many. So end of life care is being compromised by pressures. Yep, I think we'd probably all agree to that. I heard someone very senior say that a pandemic, good care goes on hold. Does it? Does it need to? I don't think so. I think we can, we can make things work. What is a bit sad is 2/3 of nurses. So this is a RCN survey. 2/3 of nurses surveyed said they did not have enough time to provide good end of life care. And I think back to my student days, it was the students who looked after people at end of life in the hospital, because they had that time because they were supernumerary. People being discharged too swiftly without necessary care packages, seeing quite a lot of that. I think around the table we'd probably say we're seeing that. And it's just the unrelenting speed, but it's sometimes better to take that time to prevent a disaster. We all know that. And I know within that, as an individual or even a team, it's quite hard to make those changes. But I guess it's about, for those people who can make the changes and for those who can feed back, when things go wrong, datexing it, reporting it back, trying to improve the systems. Now, this did break my heart. So this was someone I know's dad died in Hillingdon a few months ago, and they were really quite distressed by the care that they received. And in particular, it was a comment about not being believed when they called to say that their loved one was in pain. And it's a really tricky one, and I think this has been, I've heard this often. And as nurses, it's your PIN number, you're coming to assess a patient, your assessment and why you're giving those drugs you make in that moment. And it is really tricky, but it was quite interesting with this particular case that it was kind of a lot of back and forth about whether they were really in pain or not. And it is difficult, because I think we've also looked after patients where the family are pretty much asking us to euthanize their loved one, which obviously is illegal and not what we would be doing. But it's kind of how we as professionals make that assessment, and really are as sure as possible how we communicate with families what we do and don't do. The doctrine of double effect. So we, all the drugs that we give pretty much at end of life, in terms of the opiates and the sedative type drugs, we know can shorten life, but we're not giving it for that reason. We're giving it to control a symptom. But it's tricky. And I've been with families who say, we wouldn't treat a dog like that, you'd kill them. And it's kind of sometimes taking that time to really whittle that down. But equally, I would say, if someone called me saying that their loved one was in pain or distress, I would want to be really, really, really 100% sure before I did not give anything that were really the case. I would want to be moving them around, repositioning them, really checking that that's true, because family are our eyes and ears. They are there with their loved one longer than we are, and they're calling for a reason, even if that reason is wrong and they want us there to bump their relative off. they're asking for something. So I think it's just how we manage that. And I'd really be interested at the end with questions whether what the group's feeling are about that, because I think it is a difficult one. And I guess one of the things I quite liked about the end of life toolkit, which I know doesn't get used that often, and again, it's about extra documentation and it's quite clunky. There is a chart in there which is aimed at professionals doing their assessment of different symptoms, but then also the carers have the option to record their views on symptoms. And part of me wonders, for some family, that might be really helpful. I know there would be an argument against it for others, but I just I think sometimes we have to really accept that they are really important with caveats. I know it's not straightforward, and I know at the end of the day, you are the one giving the drug. You need to be really happy with the decision. But I wanted to cry when I heard this story, is what I'll say. So, professional barriers. So symptom control. So I've had a thought of this, had a little bit of a read around fear of hastening death and legal and professional repercussions. I bet you a lot of people on this call have been the one on the end of a needle and they've died within 20 minutes, because I know I have. And it's interesting. I worked with a consultant a few years ago who said it was only when she had to give an injection that she really thought about what that felt like, because often the doctors might be prescribing the drugs, but they're not often the ones delivering them, and how different that feels. And I've worked with nurses who've made drug errors that have resulted in the death of someone at end of life, and how that felt. It was, it's a horrible position to be in. So I think there is definitely a part of that. And equally, you're in a situation converse to the previous situation where you've got family members saying, "What are you giving? Are you going to kill them?" And being quite anxious about what you're giving. And again, I think really understanding the doctrine of double effect and being able to explain that to people is important. I looked after an 18-year-old who had quite a difficult death, and part of that I think was that he wasn't really accepting of what was happening. He had a lot of symptoms. He was in respiratory distress, and he needed an awful lot of sedation at end of life. And it was me giving all of those drugs on my own in that home, and he died with a few hours later. And the drugs that I were giving made me uncomfortable. And those of you who know me know that I am quite relaxed about giving drugs, but he needed a lot. And the support I had was someone on the end of the phone giving advice from the hospice. I was on my own. And after he died a few days later, his mum phoned me and said, "Did you kill my son?" And that's a difficult question. And I'm quite clear, no, I didn't kill him. His cancer killed him. I made him comfortable. I treated his symptoms. Did what I give him shorten his life? Yeah, probably, but I couldn't have left him in the distress he was in. But that can feel quite horrible, and it wasn't, a great conversation. She was fine. She just needed to really understand it and say it out loud. But I'd say she's probably not alone, and I think there are a lot of family out there who wonder. We have families who fear syringe drivers for the same reason. The syringe driver goes up, then they die, but it's chicken and egg about why that syringe pump was needed. So sometimes it's just really breaking down and again understanding where are they coming from, what are they concerned about. But it's a lonely place to be in someone's own home, definitely. Lack of knowledge, training, confidence. Again, the RCN paper also looked at that actually there is a lack of training around end of life. You're here today, but I don't think I know in CNWL it's not compulsory or mandatory to do anything about end of life. I know at Hillingdon Hospital they get 15 minutes on their induction. There's a lot of areas where they're looking after people at end of life who don't get formal options for training, and even if they do they have the time to attend? No, it's difficult. There might be personal, cultural, or religious beliefs that play into kind of your views about giving, support to people at end of life, and your fears about hastening someone's death and what that feels like. You know, I am lucky that I have not lost someone close to me or and been in that situation. And I've seen other palliative people, whether that's affected how they then work. It's we're all different. But sometimes I think it's just about kind of thinking back, why am I feeling that way? Where does that come from? Sometimes there's transference from us to families and back again. It's sometimes really helpful if you're feeling really uncomfortable in a situation to take time out and talk that through and really understand what might be triggering for you. Lack of communication between treating teams, yeah, institutional lack of time, resources. Again, the handovers between teams are definitely a big problem. We all know that, and I think we'd probably agree with that. So, symptom control, and when considering medicines for symptom control, you need to be taking into account the likely cause of the symptom, the individual preference and harm versus benefit. Going back to the likely cause, I think, particularly at end of life with agitation, we'd want to be ruling out, urinary retention, constipation, pain, before we're reaching for sedatives. Is there something else going on? And I know all of you do that as part of your assessment. Individual preferences, harm versus benefit. So some people might actually express as part of their end of life, they really, really want to be as alert as possible, and that's really important to them. And we need to respect that. And others might conversely say, I want to be really, really out of it. I don't want to be aware. Again, the harm versus benefit, that's going back as well to the doctrine of double effect. Individual and cultural views. It's just helpful to understand if people have lost someone before or seen someone at end of life, kind of what stuck with them, what they would be worried about, equally for the families. Thinking about other medications being used. I guess, for example, if someone's on anticonvulsants, we really need to be making sure that we're considering that as part of the anticipatory medications. And I know recently we have had issues about anticipatory medications and us being quite rigid. So we've in Hillingdon kind of always used cyclizine. As our antiemetic, regardless of why someone might need sickness medication. So if you think about it, some of the people we meet might already have complicated anti-sickness medication regimes, and then we're just replacing it with cyclizine, and that's not necessarily the right thing to do. But it's kind of just we've fallen into that habit. So sometimes it's about really thinking for that individual patient, what specific things do they need? Do they need a different type of antiemetic because the cause of their sickness is different? Do they need a higher dose of midazolam to start with to replace the Keppra? There's all these things that kind of we've fallen into anticipatory medications being quite prescriptive, so it was easy to do and everyone felt comfortable and we knew what to request and the GPs knew what to prescribe and everyone was kind of on the same page. But the risk with that is sometimes it becomes too shoehorned and pigeonholed, and that in itself can cause harm to the patient, or it causes underdosing, or or causes bad symptoms because of side effects because we've given the wrong drug. So I think sometimes we get very set on, well, why am I not seeing these set doses? This is wrong. But it isn't necessarily wrong. It might be it's appropriate for that patient. So it's just good to stop and think sometimes. And again, the one good thing I would say about the Pan London chart that I'm pleased about is the fact they've got the patch option on there, because I've always worried that we don't always know what patches people have got on. The fact that it specifies if they've got a patch on and what doses at least makes you stop and think, is that PRN dose correct? Does it need to be higher? Oh no, that is why it's that high, because they've got that background. Um, it's also just worthwhile thinking about the drugs we give and how they might worsen other symptoms. So, cyclizine with heart failure, most people know that. And I would say again, at end of life, we don't worry so much about that. But equally, we wouldn't want people on cyclizine for a long period of time if it's going to exacerbate their heart failure and cause more symptoms. We're always thinking the balance between I want the person to feel as good as possible for as long as possible, and I don't want what I am doing to make them feel worse. It's that kind of that balance. The Hillingdon mini guides and Pan guides and Aid Memoir are kind of the local kind of guidance that's around. The Pan guides obviously is more national and kind of agreed, and it's the hyperlink there is kind of an online version of the Pan guidelines, and it's quite useful because it's actually got a syringe driver compatibility built-in tool in it, so you can put in different drugs to see if they're compatible. It's free to use, so I'd say it's a good thing to download on your desktop or your mobile phone. Support. So let's think about this. Available support. We are using H for All more and more. So that's Hillingdon for All, and that's a number of charities that have come together. They used to only look after people over the age of 65, but actually now it's open to all people over the age of 18. The restrictions are the person has to be a Hillingdon resident, and for people on the borders that can be complicated. So even if people have got a Hillingdon GP but they're paying their taxes to Hertfordshire, they can't access H for All. So that's just a restriction to be aware of. But they can be really helpful kind of to tap into local charitable support for people and be really helpful with, benefits things and all different stuff. If people have got cancer, you've got Macmillan, they've got lots of free phone numbers and can be really helpful. They've got a benefits free phone number. I found this this next one turned to us really useful recently for someone who Macmillan turned down for a grant, because Macmillan will only give money every so often. And I had someone who's a refugee and has no means to public funds. So I was desperate trying to work out how to help her. This organisation is great, turned to us, because you literally put in, like, it's a terminally ill person, they live in this area, they've got children, they're this religion, and it pops up with all these different local charities that will help. And how to do applications for them. So it's really helpful. Of course, you've got Citizens Advice Bureau, the cancer centres in the hospitals. So you've got the Macmillan Centre at Hillingdon Hospital, you've got the Linda Jackson at Mount Vernon. They can be really helpful, plugging people up to the right things. Also thinking about disease-specific support. So motor neuron disease, the MNDA, Motor Neuron Disease Association, are fantastic. They do loads of things for people who are affected by motor neuron disease. British Heart Foundation. You've also got the Carers Trust, big up them again. So honestly, the people that we have linked into them have been so grateful for the help and support. And when COVID and lockdown kind of restrictions change again, they will be doing the sort of carers support group coffee mornings and different things. And a lot of it is about the peer support that they can offer each other, which can be really helpful. And honestly, I wanted to join the gardening group, but I wasn't allowed. We've got the hospices, who obviously do an awful lot. So Harlington Hospice, Michael Sobel Hospice, and kind of within that, obviously the therapies and the night sit service, the stuff that comes from out from that. I can't talk. I just wanted to briefly touch on religious considerations. So I know this has certainly come up in the community a few times. Although it doesn't say this, so I got most of this information from the Spiritual Gate website, which I've added in the references. It kind of talks about, the important things to remember when someone's died who's follows the Muslim faith. One of the things that we've run into quite a few times in recent, well, for as long as I've been doing this actually, is kind of the wish to have a quick burial. Um, Now, the issue with this out of hours is that the GP would need to be willing to do the death certificate to enable a burial to happen. And really, the GP doesn't have to do that. So you may find a GP who'd be willing to be contacted out of hours. And when I say out of hours, I would mean, not the middle of the night, but like maybe 9 o'clock in the morning on a Saturday or 9 o'clock in the morning on a Sunday, because the registry office in Hillingdon do offer the ability to register a death out of hours, which is also what would need to happen. Um, but the GP doesn't have to do that. And actually, the poor GP, it's a lot on them. And out of hours GP can't do it. But what I would suggest is it's something that we would need to identify for that individual person and have discussions about as early as possible. And, maybe manage expectations to say, do you know what, this isn't possible. And, we would try and facilitate as soon as possible in the working week, but out of hours, it can't happen. Or there may be a discussion with the GP who says, do you know what, yep, I'm happy for it. And you could actually maybe even record and coordinate my care record, how that would work and who to contact. But it may be more about managing that expectation. And yeah, and I think it was just, it was just thinking again about kind of particularly, I think now that we're verifying deaf and nursing being involved in last offices, kind of, being clear with the family what they would want you to do or not do to respect kind of religious and cultural beliefs. But I do think the distress about not being able to arrange a quick burial, certainly in the community, does cause a lot of distress, and it's probably something that we could do more about to avoid or kind of recognize and act on sooner. I just also, I know for Jewish people, ideally, again, it would be the idea of having a quick burial if possible. So it was kind of just thinking about that. So it was a very brief touch on the kind of specific thoughts about different faiths and how important both care after death may be, but also kind of then a quick burial might need to be. So after death at home. So registering the death out of hours is kind of what I went through. And it is just being really clear about the language, because I hear health professionals getting mixed up between death certificates, death verification. Out of hours GPs cannot do death certificates. They can verify the death, but it is the patient's registered GP who would need to be doing the death certificate, or the doctor looking after them in the hospital or the hospice. This is information we have got if we did need to register a death out of hours, as in not us but the family. So this is kind of how the system could work, but this relies on the GP having done the death certificate. But it's just useful to kind of know. And obviously the benefit with COVID is things can now be electronically emailed, so the death certificate can be emailed to the civic centre, but they still do need contact with the family to be able to do the final bits of it. Death verification last offices. So I think this is something that I think families have certainly fed back has been helpful to them in terms of their bereavement care. And I am hopeful that will continue, because we lost a syringe driver not having this. So to me, death verification last offices kind of go really hand in hand. And it's kind of one of the final acts you can do for someone. And I think it's really important. And it is, it's called RNVOED, which is Registered Nurse Verification of Expected Death. And it is a bit of a mouthful, but it is very set criteria. So people have to kind of have been seen by their GP, video or face-to-face within 28 days, recognised to be dying of an expected death. So i.e. not that they've suddenly dropped dead and it was unexpected. It needs to be people who are recognised to be dying. LAS do verify all deaths that they're called to, but they call it verifying life extinct, which is slightly different. But it's just to kind of know that, because we do have patients verified by LAS. And the last one we had, they did throw our syringe driver away because it was given back to a pharmacist who threw it in the bin. That made me not happy. But I think it's just, it's just bearing in mind that sometimes I think we don't realize how important it can be to family for us to be involved in that final kind of last act of care, and not lose syringe drivers to mortuaries or bins. So care after death. We're looking at kind of written information that's given to families after deaths. So there is the government what to do when someone dies, which is probably out of date now with COVID. But it's quite helpful just because it's quite basic. Funeral directors often give people written information as well. We do. We've got an end of life board later this afternoon, and I just wanted to float past. Hillingdon Hospital has actually created a guide for after death at home. So it's actually about community, but it's written by the hospital, and it's been what do I mean? It's been not funded. That's not. It's kind of sponsored by, I think, like a group of funeral directors. So it's kind of like a directory of funeral directors have sponsored it, but it's really good. I'm kind of hoping we might be able to use it, because I think, if you think when someone's just died, people don't take much in. They're a bit like shocked. So it's kind of, if written information can be left, it can be really helpful. And it's just, it's just taking that time to kind of either check in with them at that moment or be calling back to check that they're okay. But it is true, funeral directors do a lot of that hand holding and support. It's useful to kind of know about the bereavement payment. So this is for people who die under the age of 65, that their loved one potentially may be able to get bereavement payment. But it is means tested. And equally a funeral payment, so that's kind of a one-off payment towards the cost of a funeral, because the average no whistles and no bells funeral costs about $5,000. So it's not something that a lot of people think about or save up for. So it's kind of useful to kind of know about that. Equipment and drugs. Some of the complaints we've had is for family not understanding what their responsibility was after death and what they needed to do. So again, I think it's just taking that time. Equipment causes massive problems. So we have had agreement from the CCG that we can get equipment lifted after death within 3 days. In very exceptional circumstances, we can contact LBH to get authorization to lift sooner. But again, that's quite a big deal. This is probably a hospital bed at the very least in a commode, potentially in someone's living room. And it's so difficult to just leave that for 3 days even sometimes. So I would stress, if there's someone where that's really, really going to be distressing, to either have an early conversation about managing that expectation of 3 days, or we get in touch with LBH and come to me if that happens, because I know who to contact. Obviously, we can't do it all the time because they would get wind of that. But when it's exceptional, they will do it within the same day even, because it can be horrible. It's a very meaningful thing to have just tripping over in the middle of the room. It's not like you can just shut a door and ignore it. Also, return of drugs. Again, I think this is something that has caused problems and distress. So families thought we'd be responsible for it because we were managing the syringe driver. And obviously, you're told very much as a nurse you shouldn't be carrying these drugs unless there's a risk and it needs to be taken out for that reason. So again, it's just kind of going through that. I would urge you to use the anticipatory medication leaflet that is part of the MarChart pack, because that kind of does go through how to store them, what happens after they're not needed. It doesn't say it in a horrible way. It's not kind of like once people die, they're not needed. It's nicely written. So it's probably again a bit of the preparation about that. Oh, I just put this in there because this was quite useful to know. If you trip over someone who has died and they don't have any next of kin, this is how to sort out a funeral director. So this is from LBH. So we have had this situation in the community where a patient had died, and unfortunately their relative was actually in hospital dying of COVID themselves, so couldn't be contacted. So we were able to get the person collected from home using this sort of format. If then they'd been able to get in touch and found out a different way, they could have then, their own funeral director could have collected them from W. Sherry. So it's not a one-way ticket. Oh my God, if it all goes wrong, but it is really helpful to know if you're in that situation. Trust me, you don't want to be in that situation. Think, what do I do with this dead person? It's just useful to have that little bit of information. So it is via LBH. Okay.